Hey everyone, welcome back to the DNS podcast. Today we're focusing in on an important and timely topic, the transition of ICD-10 to ICD-11 and what that means for documenting and diagnosing adult malnutrition, soon to be renamed undernutrition starting in 2027. For those who may not be as familiar, ICD stands for the International Classification of Diseases. It is the global diagnostic classification system developed and maintained by the World Health Organization. ICD codes are used worldwide to standardize how diseases and health conditions are defined, documented, tracked, reported, and reimbursed. In the United States and many other countries, ICD codes directly impact clinical documentation, quality metrics, research data, hospital reporting, and of course, financial reimbursement. When these codes change, it affects the electronic medical record, hospital billing workflows, institutional policies, and day-to-day clinical practice. Beginning in 2027, ICD-11 will formally include a code for adult undernutrition, replacing the terminology of malnutrition in this context and aligning diagnostic criteria with the Global Leadership Initiative on Malnutrition, or the GLIM framework. This means clinicians and healthcare organizations need to prepare now, likely updating their EMR systems and possibly their clinical workflows to ensure appropriate documentation and reimbursement. Joining us today is Stacy Pelekhaty, a senior clinical nutrition specialist at the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center in Baltimore. Stacy has been a dietitian for over 15 years and has received awards for innovation in healthcare, malnutrition advocacy, and excellence in patient care. Her research focuses on energy and protein needs, malnutrition assessment, and the clinical impact of nutrition interventions, specifically in the trauma and ECMO patient population. She is a fellow of the Academy of Nutrition and Dietetics and a member of the 2026 Aspen's Fellow class. Today, we'll talk about these ICD-11 changes, what that means for dietitians in particular, and how we can all be ready when those new codes roll into place.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between. This podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
All right, well, today we're talking about ICD-11 changes and what that means for clinical dietitians, how they align with existing validated assessment tools, and why early preparation is so very critical. We're also going to touch on how DNS in particular can help lead the education and advocacy efforts as implementation approaches. So Stacy, thank you so much for joining us today to share your expertise on this topic.
Yeah, thanks for inviting me.
So can we start by having you give us a high-level overview of what exactly is changing with ICD-11 in 2027, specifically regarding adult malnutrition?
Yeah, so right now under ICD-10, there are a couple of codes for malnutrition, mostly the E40 codes, and they're very generic. It's generally mild, moderate, and severe protein calorie malnutrition. There's also cachexia and failure to thrive. And when we transition into ICD-11, the codes get slightly more specific and align with the starvation and disease-based paradigms that were first introduced in 2009 by Gordon Jensen et al., and then later codified actually originally in the AIM criteria, and then later adopted in the GLIM criteria as well. So the new ICD-11 codes are actually much more consistent with the way that we as dietitians think about malnutrition in the clinical space.
And I understand that one of the most notable changes is the terminology shift from malnutrition to, quote, undernutrition. So why is that change so very significant for us?
Yeah, that's a really great question. And I think it's a big question in the front of everybody's mind, particularly because I think it will require a lot of careful framing particularly in our notes and when we're having conversations with families and stakeholders, and a lot of front end education with our physician colleagues. Because when we think about malnutrition globally, not all patients who are malnourished are particularly undernourished in that they're receiving inadequate nutrition, but a lot of times our patients are not able to utilize the nutrition that they are taking in. So we see that a lot in specific disease states, in malabsorptive conditions, and in high inflammatory states. And one of the ways that we can help to conceptualize and contextualize this for the other members and the other key stakeholders is by thinking about this as a metabolic starvation. And that is language that can help to help people understand. Because if we just put it out there as this patient is undernourished, when we're also documenting that patients have not necessarily had inadequate nutrition intake over a period of time, we may run into a situation where those two pieces of information aren't necessarily making sense together. So it will require a little bit more careful framing of the information to make sure all of those dots connect easily.
And that's important from an insurance side, right? Because they're going to do chart reviews to make sure that the codes align with the documentation. So a
Yes.
mismatch can cause a problem.
Yes, exactly, exactly. We also don't want families looking at this and thinking that we on the other side are not doing everything in our power to take the best possible care of our patients at the bedside. Sometimes we can do everything right and patients can still develop malnutrition because, we can't always we can't always support the metabolism doing the best possible things with the nutrition that it's provided.
Sure. Well, the ICD-11 code requires one etiologic and one phenotypic criteria. So can you walk us through what those criteria include and how they align with the GLIM framework?
Yeah. So phenotypic criteria is a fancy way of saying a cause of malnutrition. And so this would be either inadequate nutrition intake or assimilation. So this is either not consuming enough nutrition, either due to volitional choice or lack of access, or an inability to assimilate the nutrition that you are consuming due to malabsorptive conditions, diarrhea, vomiting, other symptomology of your disease process. The other cause of malnutrition would be inflammatory metabolic changes from chronic or acute disease processes. And that's really similar to a lot of what we already think of, regardless of whatever framework you're using to diagnose malnutrition. The phenotypic criteria would be the signs or symptoms that your patient is malnourished. So under the ICD-11 framework and the ICD-11 coding, this would be a low BMI with specific cut points for ages, low muscle mass, or weight loss with specific amounts for within the last 6 months or beyond 6 months. And so regardless, again, of whatever framework you're using for malnutrition, these are really common diagnostic criterion that most of us are already using in practice. I think the one that not everybody uses would be the low BMI.
Okay. And how do common assessment tools like the AAIM, the SGA, or the MNA fit into this new framework?
Right. So if you're using GLIM, all of these diagnostic criteria are already really familiar because it's consistent with GLIM. And if you're using AIM, MNA, or SGA, it might look a little bit different than what you're familiar with. But really, regardless, all of these frameworks are using in some way, shape, or form, somewhere along your diagnostic tool, all of these different points. Again, with the exception, if you're using AIM, you might not be looking at that low BMI piece quite as much. So if you're not using GLIM, you don't have to change to GLIM. I'll highlight one of the things that we do at my institution. We do diagnose malnutrition using the GLIM framework, but we use the AIM criteria as a guidance for our nutrition assessment. So there are ways that the different frameworks can dovetail together to work in tandem as a holistic nutrition assessment to make sure you're not, for example, leaving adipose tissue wasting at the wayside because you're only focusing on these specific criteria over here. It is important that we are looking at the patient as a whole patient, recognizing that when does come down to that coding and billing, we're making sure that we have these specific criteria within our notes very clearly documented.
So the changes that we're talking about, we said are 2027, right? And right now we're sitting like on the cusp of spring of 26. So what practical steps should clinicians and broader the healthcare organizations be talking about now, especially thinking about like EMR updates that need to be rolled in? Like what should we be doing in 2026 to be ready when this goes live?
Yeah. So I think some of the important things, there are some really key steps to take right now, because this is something that we don't want any of this to catch us by surprise. And I think if we wait for the ICD-11 to start rolling out, there's going to be a lot of scrambling at the last minute. It is likely that the United States is going to adopt ICD-11 later than a lot of other countries. So we probably will have a little bit more lead time than some of our other, say, European and Asian partners, but we shouldn't wait for the last minute. So some of the things that we can definitely start looking at, number one, looking at what are we currently documenting? So are you currently capturing things like inflammation, causes of inflammation? Are you currently capturing nutrition intake in your notes? Are you currently capturing signs and symptoms of malabsorption? Is all of that getting very clearly documented? And then also all of the signs and symptoms, are you documenting your BMIs very clearly? Do you have the specific age thresholds for BMI? As well as how are you documenting your muscle mass and how frequently are you reassessing that muscle mass? And then finally, how frequently are you evaluating weight and weight loss? Where is that getting documented and how easy is that to find? And is it all getting documented together in a really easy to identify way? And when all of that is documented and a malnutrition diagnosis is made, are you co-documenting that with a licensed independent practitioner like a physician or a nurse practitioner, to make that nutrition diagnosis into a medical diagnosis, recognizing that we as dietitians make nutrition diagnoses, but those nutrition diagnoses are not the basis for coding and billing. If you are already doing that and you already have that in place, then working with your coding and billing team to understand what are your insurance codings like? Do you have a high rate of denials currently? And if you do, what is the source of your denials? That way you can work with that to kind of understand what are any existing deficits in your documentation, shore all of those up under ICD-10, and then look ahead to ICD-11 to see any changes that need to be made. Your coding and billing colleagues will also be incredibly beneficial, making sure that you have those lines of communication open now and that they stay open through this entire process. If you haven't already started to consider adopting the Malnutrition Care Score, the MCS, which was previously called the Global Malnutrition Composite Score, that's something that you can look at least a framework into this process. Even if your electronic health record isn't in a position to support it currently, it can at least guide some of the documentation requirements that can support something like transitioning into ICD-11.
Well, I think it's important too for maybe our dietitian listeners who have not been part of these kinds of updates and changes before. EMRs go on freezes a lot, at least in my experience. Every time we wanted to make a change, we were told, well, you can't until this date because we're on a code freeze. So important to get a jump start. So if there is a freeze in place, you still have time to do the work.
That's such a good point. It's such a good point.
So what are some of the coding and billing implications that dietitians and even our administrators should be aware of if we don't take the appropriate actions?
Right. So if you are not taking action now, one of the potential challenges that you can run into is that you can start to get a lot of denials around malnutrition coding and billing. And if you start to get a lot of denials around that, um, then that can start to have negative implications for your hospital's reimbursement schemes and programs, particularly if you are an institution that has already adopted the malnutrition care score. If now you start to have deficits recognized in your diagnosis rates, then that becomes incredibly problematic because of the system that the malnutrition care score flows into as a reimbursement model. When you're not meeting the benchmarks for that model, it makes a huge impact on your hospital's reimbursement. So it's important to know if you are doing MCS. And if you are doing MCS, is that something that you've adopted as a measure? And if so, then you need to make sure that you are talking with your quality team and your coding and billing team to make sure everything is in place ahead of ICD-11. Or if they actually potentially would want to freeze that as a quality measure during the transition to make sure that any changes in the coding and billing around ICD-11 wouldn't impact the hospital's quality scores because of the quality schema. Um, but the one of the really big concerns is the possibility for increased insurance denials. I think if everybody is prepared and having these open lines of communication, it's not a foregone conclusion that we will have increased denials. It's just more if we're not prepared and we're not being proactive, that's when we start to be concerned.
Well, and I think I'm sure you're in the same boat. Like we love data, we love quality improvement projects. So denials is something that once you get access, you can easily track that and you can track the number or the dollars of denials you're seeing month over month. And you would know, one, do you really have a problem with denials? And then is that problem getting better or worse? Because denial doesn't mean non-payment. It means more work has to be done. The docs have to be queried and we have to do more work to try to get paid.
Yeah.
So definitely slows down productivity alongside with the potential financial loss.
Yeah. And I can tell you, we adopted, we don't have MCS in place, but our co-documentation process follows the model of MCS. And I reached out to our coding and billing team ahead of ICD-11 when I found out that this was coming down the pike. And with our coding and billing team and our MCS process, so our co-documentation note includes the ICD-10 code, the cause of malnutrition, which would be the etiological criteria under GLIM, the signs and symptoms that we're using to make the diagnosis, so the phenotypic criteria under GLIM, the treatment plan, so the dietitian's recommendations that are being followed, and then also the monitoring plan, which are all the requirements that are needed not only for the initial coding capture, but any potential questions that the insurance companies may have. In a 12-month period, we had 3,000 coding captures for malnutrition, and we had 3 insurance denials. And those denials were actually not related to documentation deficits. They were related to excessive hospital length of stays, probably because the patients were severely malnourished, but the insurance companies felt that the length of stay was so excessive that they denied a significant portion of the hospitalization.
Sure.
So I think that that just goes to show that when you've worked very closely with your coding and billing team to make sure that you have everything needed there, you really can impact not only the coding and billing capture on the front end, but also those denials on the back end.
Yeah. And talk about a win for your team to say out of that many, you had 3. Like that's really impressive. So congratulations on that. That's huge.
Thanks.
So you work in a high acuity trauma center.
Mhm.
How do you anticipate this change impacting your documentation practices, critical care, trauma, and your ECMO population?
Yeah, I think one of the big challenges that we see is the addition of the undernutrition as a requirement in the coding um, the coding language. And so it has to be included in your ICD-11 code name. And that is going to require a lot of conversation and education with a lot of our colleagues on on the actual documentation side. So right now, when we diagnose with malnutrition, I have a lot of conversations with my physicians about it's not that we didn't do our jobs. It's not that we didn't take care of the patients. It's that we did everything humanly possible. And this patient was so ill that they developed malnutrition due to inflammatory metabolic changes. And so it's just going to be a little bit more front loading those conversations and making sure that that's very clear. And I think having that language of undernutrition in the setting of metabolic starvation, due to these inflammatory metabolic changes is really helpful in framing that conversation. And then also knowing that our notes are patient facing and family facing, preparing the families for those potentially seeing those notes and those diagnoses that the patient was not unfed. The patient developed this diagnosis and this condition as a result of how sick they are.
Well, what are groups like DNS, ASN, and ASPEN doing to help us all prepare for ICD-11?
Yeah. So there was very recently in February a co-publication across all three organizations, the Academy and ASN and Aspen, just setting the stage for the fact that this is coming down the pike and what it means for everybody. Currently, the three organizations are working together to develop a crosswalk for SGA, AIM, MNA, and GLIM. So, regardless of which framework you're using, you'll understand how you can implement ICD-11 using your current framework. Because what we also want to make sure is nobody feels that they have to abandon a practice that they feel is the best possible care for their patient in order to meet a coding and billing requirement. You can do both. You can use the framework you think is best suited to your care setting and meet this coding and billing requirement. And I think these crosswalks are going to be critical to supporting practitioners at the bedside. So that right now is the primary focus of a lot of these organizations.
So, looking ahead, how do you think aligning the ICD-11 and GLIM will strengthen the recognition and value of nutrition care within the healthcare system?
So I think one of the key things that this is going to do for dietitians and nutrition care across multiple settings, but hospitals in particular, is we know that malnutrition is an under-recognized complication facing many of our patients. If we think about a lot of the research, like Peggy Gunter's research that's been published, the discrepancy between what we know the prevalence of malnutrition to be and what the coding capture of malnutrition is are they're worlds apart.
Mhm.
And so having coding and billing that matches what our diagnostic criteria and frameworks are will help to align these processes as long as we are having seats at these tables and having the conversations that need to be had so that we're prepared for when ICD-11 is rolled out.
So really, I think it's documenting the work that's already being done, like you said, and getting paid for that care.
Yes, exactly. And I think it just serves to really highlight and raise the reputation of what
Mhm.
dietitians are doing at the bedside and the care that we're providing and the impact that we have on our patients and on organizations.
Well, we know that one person or one specialty, excuse me, cannot do this alone. So, how can dietitians effectively collaborate with the coding team, your CDI team, your physicians, and other folks to help ensure the accurate implementation of the new undernutrition code?
Right. So I think data talks, right? And we love a data-driven approach. And so I think having information and going to the teams. So being able to say, these are our rates of malnutrition currently, and we need to make sure that as ICD-11 rolls out, we're not getting denials on this proportion of our patients so that we are ironclad in our processes. So, for example, dietitians are diagnosing malnutrition in 20% of hospitalized patients, and we need to have a co-documentation process in place that meets the coding and billing criteria so that once ICD-11 is in place, we have all of this documentation already ready to go
Mhm.
that is matching what the coding needs to be so that there aren't denials coming down the pike and there's not money left on the table. Um, and recognizing that that's going to impact the hospital's bottom line. And I think when you're really able to highlight all of that, I think it's an opportunity if you don't already have that co-documentation process in place to put one in place. And if you do, it's an opportunity to really protect it because I think if you have it in place and you start getting lots of denials, there's a chance it gets really questioned whether or not it's beneficial for the organization. And if you don't have it in place and there's the concern of denials after ICD-11 comes into play, then it's going to be even a harder sell. So I think, getting that data ready for these are our rates of diagnosis. And if we get this in place ahead of time, this is what we can do for the organization.
Well,
And then just
Stacy,
getting everybody in a room, just
yeah,
getting everybody in a room at a table.
that's awesome. Well, thank you so much for sharing your expertise. I know this is a very complex rollout. You make it sound super simple, which I know it's not. But you've given us, I think, a nice roadmap and some resources and organizations and things to look forward to. So thank you so much for sharing this information with us today.
It's my pleasure. Thank you again so much for having me.
And listeners, you've heard it from Stacy. Now's the time to start these conversations. Talk to your EMR teams this year. Look at your documentation templates. And of course, be on the lookout from Aspen, the Academy, DNS, ASN. There's a ton of information forthcoming, so we'd love to help you out. And of course, we have your forum too that you can post questions. So be sure to visit our website, dnsdpg.org. Until next time, I'm Christina Rollins. Thanks for listening.